Welcome to my next talk. Today I want to actually go over ultrasound lung B lines and also pleural effusions. I also will cover actually some of the cysts you may actually see from the views when also looking at this in terms of renal and hepatic cysts. So the real questions are, what are B lines and what are also the pleural effusions? When should you sort of look for them, and how do you look for them, and what do they actually look like, which is what you want to focus on. So with ultrasound B lines, they're actually a reverberation type of artifact. So it's a vertical artifact, a comet tail type, and originates generally from water-thickened sort of pulmonary interlobular septa. So it's actually just a vertical artifact we see going down the screen. They also talk about A lines, which are horizontal reverberation, but they don't have any great significance really need to worry about. With a differential diagnosis of B lines, we need to consider, is it a cardiogenic or a non-cardiogenic cause underlying it? In reality, the actual presence of B lines themselves are inherently non-specific. You can't say, yes, this is cardiac or non-cardiac by looking at it, so it has to look at the other elements to just make that decision. So, when seen in left ventricular dysfunction or with valvular heart disease, diffuse bilateral B lines is highly indicative that you've probably got some pulmonary edema underlying. In contrast, in presence of a normal left ventricle with elements of B lines being seen, it does suggest more of a non-cardiogenic cause being more likely. And so, when should we look for them? And so, elements where there may be some form of pulmonary congestion, we want to sort of look and then think about is there an element of that can be seen by the presence of the B lines. And so various conditions which may then be associated with elevated left atrial pressure become significant. And so how do we look for them? Patients can generally be on the back or on the side. It doesn't really actually matter too much, or even in the sitting position. All the chest can generally be easily scanned by ultrasound, so in essence, anywhere can be looked at to find them. Various approaches have been sort of proposed with various sites suggested and different scoring systems. Sometimes read about lung sliding, which is not often something you talk about in the context of pneumothorax, but not really relevant to this talk. And so when I actually talk about practical terms of really looking for lung B lines, though, in reality, what I'm actually doing is looking in the anterior chest, normally around the mid-clavicular line, sort of coming down 2 or 3 interspaces, and looking in a coronal plane, and then I'll generally capture a 2 to 3 beat clip just to demonstrate the presence or absence of B lines. I may then look at other sites if I do detect some suggestion of it from the first pictures. In reality, it actually adds about 30 seconds scanning time to do this, though. If I'm also looking at the back for pleural effusions, then I'll also take note of the lungs because you can see B lines from there as well. So when would I consider looking for it? Well, if I've got a heart like this that really isn't working very well, then yes, I would be considering actually looking for B lines. Similarly as well, if I've got something like this where I've got a regional wall, some regional dysfunction, but I've also got an RVC that's not collapsing very well, potentially I've got some history there as well of diastolic dysfunction. If I also, in this case, I've got severe pulmonary hypertension, or if I've got a right ventricle that doesn't work, or I do have pericardial effusion, then I may also consider just looking for B lines as well. In this case here, I've got quite severe mitral regurgitation, so again, I would consider looking for B lines in that context. And then another cause I would also just want to have a look and just make sure is the presence of cardiac amyloid, as can be seen with a very thickened, bright-looking LV in this case. So, what they look like? Well, normally when we look, we can actually see a line at the top there indicating the pleura, and then we have relatively consistent density across there, but no definite sort of lines going across to be seen. Very faint ones, but nothing true that goes from the pleural line all the way down. And so again, just a normal looking one. This one's actually looking from the back though. You can see the lung field cross over the diaphragm more or less in the relative middle of the picture just here, and lung and organ down below there. But again, no sign of B lines. This one here, it's just got a few little B lines you can actually be seeing now projecting down vertically in the middle of the picture. And again, just a few little B lines as we look here. And so there's sort of multiple, and they come and go as the lungs move over. And again, just a few more. Now they're starting to appear a lot more dense in comparison, so this one's more positive than the previous image. And again, just a few more here around there. And as they sort of come and go with the breathing, but you can see these definite artifacts that appear. This is actually looking from behind again. So again, got the diaphragm relatively in the middle as the lungs move down across as they go from right to left in the picture. And there's just a few little bee lines mixed into the lungs that can be seen there. And again, this is just looking from the back, a little bit higher up this time though, just focusing more on the lungs, and again, some bee lines to be seen. And this is also looking for the back on the right, and again, just a few lines you can sort of see projecting down. This is just a left anterior view here, and we can see these various lines spread throughout the picture. And just a few more there. And so this patient here has actually got pulmonary fibrosis and a relatively normal heart. So in this case, we'd say the presence of these B lines would be more indicative actually of the pulmonary fibrosis rather than being related to pulmonary congestion. And so this is just the right lung as well, so there's bilateral B lines present in that patient. And just a reminder again of what no B lines looks like. So again, there's just no significant vertical lines seen. So next, moving on to pleural effusions. Well, what are they? Well, they're fluid buildup in that relative pleural space. It can be a transudate or an exudate. So the transudates we associate with an increase in hydrostatic pressure or a decrease in the colloidal pressure. Or an exudate, which is normally can be associated with a inflammatory process such as infection or malignancy. So causes can include, of course, heart, kidney, or liver disease. Here, of course, we're focusing on the heart causes. Pressure in the blood vessels, then forcing fluid into that pleural cavity, end up being the end result. Inflammation, infection, or lung injury, of course, or cancer or trauma can also cause infusions. And so, when we think about looking for them, well, if the patient has a history of shortness of breath, or swelling of ankles, or painful breathing, or cough, if they've got suspected heart failure, or CCF, or pulmonary embolism, or cardiac amyloid, if they've got a history of recent chest radiation, lung or breast cancer, lung infection, chronic kidney disease, chest trauma or surgery, or presence of a pericardial effusion, because we always think about pleuropericarditis rather than being an isolated phenomena, and also when there's left ventricular dysfunction or B lines present as we've seen before. And so how do we look for them? We're looking at the back, so I'll get the patient actually sitting upright. Even though we can see them parasternal and apical views, we can't really grade the amount in those views compared to looking at the paravertebral window. So they're sitting upright, probe faces vertically and parallel to the spine with the index marker up, and that way the lung will appear on the right-hand side of the picture. The diaphragm will be relatively in the middle as you slide down to get to that point where it's relatively in the middle, and you can see the lung fields move from the right to the left side of the image. And so here's a patient here. There was no particular effusion to be seen. A little renal cyst, looks like it's over on the left there, you can see in the kidney, but no effusion to be seen on that one. This patient, as I take a breath in, you can actually see that a little bit of fluid between the diaphragm and the actual lung there though, so there's a little bit of fluid there. And here's just another view again of just a very trivial effusion. It's just a very little tiny bit, rather than being no space, it's just a little bit of fluid in there. Here's just more of a smaller one. It's a couple of centimetres in size, and so it's just a little bit of fluid there. This patient here is looking to say, we can see some fluid behind the heart, but it's very hard to tell how much that really is just by looking at it from the parasternal window. When actually looking from behind, it's actually a relatively small effusion, even though it looks relatively large in that parasternal view. It's only about 2.2 centimetres in size, which isn't really that big. And then on the same patient on the right, again, the small little right pleural effusion. And again, looking from the parasternal, we couldn't tell the patient had a right pleural effusion. In the comparison, this one's heading more towards that moderate sort of size, probably around 4 centimetres on measurement, when you're actually looking at how wide it actually is across. And this is a larger pleural effusion in comparison. This one's close to 7 centimetres in distance across. This is just another patient here. I mean, it's probably a moderate size effusion, but we can see the line across there of the pericardium and some pericardial fluid underneath it. The other value of this window can be sometimes to actually view the heart, so you can see the heart very nicely in this view. We also see the pericardium there. It's one of the rare times we can measure true pericardial thickness, where we have both pleural and pericardial fluid. In some patients, this may be actually a very good window to actually look at and see the heart. And here's just a short access of that same patient. In comparison to the parasternal long axis view here. The other thing you can actually look and see through the back is actually the inferior vena cava as well. So the IVC, when looking for collapse, when it can't be visualized from the front, the other alternative is actually look from behind as well, and you can see a degree of collapse with breathing. And so when it considers sort of sizing them, there's not really a lot of data out there, so these more or less were internally created ones over the years. So when we think about a trivial one, we're just seeing a little bit of fluid, normally often less than a centimetre or so, whereas a small effusion we consider often about 1 to 3 centimetres, where moderate we're heading more 3 to 5, and then large we're heading more sort of that 5, 6 plus sort of size. And so one of the things we can often see from the back as well when we're looking for these effusions can be actually renal cysts. And they can be isolated or they can be multiple, such as with polycystic kidney disease, which can be associated with impaired liver function. And so they can just be simple, isolated and small. So this one here is only 2 to 3 centimetres in size, not very little, not very big I mean. And here's a much larger one in comparison. And again, another large one here in isolation. And then even a larger one, or you can see a big one and another small one on top of it, and probably another one down below that as well. When you look at that one, it's actually about 13 centimetres in size, so they can get quite large. Another thing we consider as well sometimes is cysts, hepatic cysts, and so these are normally considered seen when you're looking at that subcostal window. Generally they're benign. In rare cases they can become cancerous or lead to liver failure. There can be polycystic liver processes going on as well, and in some regions of the world they can also be associated with tapeworms. And so here, just looking, you can see the IVC at the bottom of the picture, and so when looking at the IVC you can see this cyst above it in the liver. Again, here's just a little small cyst, and then a large cyst in comparison. Again, quite a good size for that one. So thank you for watching, and I'll leave it there.